Today I'd like to talk about 3 contemporary therapies for recovery from addiction. I recently had a chance to review psychologist Cynthia Osborne, who provided an overview of psychotherapeutic approaches to working with addiction. What I'd like to do is highlight a few of her key points, ones that might be easy to miss and that have practical import. She proposed an integrative view, very similar to what we're developing here in our program in addiction studies at Cal Southern. The title that she gives for her integrative approach to recovery, working with recovery, is Informed Eclecticism. And this means bringing in multiple perspectives, but doing so in a prescriptive way rather than more of a kind of a random or unreflected way. What I'd like to do is draw in 3 of the therapy models that she integrates into her prescriptive or informed eclecticism and paint out a few practical applications. The goal of any of these forms of psychotherapy is to add support and behavioral encouragement to ongoing 12-step work. In fact, I recommend you to my video on integrating therapy with 12-step programs, and Cynthia Osborne's summary that I'm reviewing right now has very much the same spirit as that video. In introducing one of the models, namely cognitive behavior approaches, she suggests something that was refreshing to read, and that is that to be truly helpful, for example, if you're working with a recovering addict who is struggling with cravings, substance abuse counselors should really have an intimate or first-hand experience of what it's like to struggle to stay clean. So what Osborne suggests is that the therapist or the substance abuse counselor voluntarily abstain from something important to themselves. She recommends, for example, a behavior or a beverage or a food item. The idea here is to enter into an actual, what she calls, abstinence contract while practicing as a counselor. I think this is an enlightened approach. Adopting this abstinence contract, the substance abuse counselor, whether he or she is recovering from chemical dependency or not, for sure can acquire a greater empathy and sensitivity to what the client's going through subjectively. Really, I think it's a great model for psychotherapists in terms of humility, as well as enhancing, I think, their ability to be present with exactly what it's like to give up something that's important to you. Next, Osborne describes what she refers to as the community reinforcement approach. She, like a number of authors in this area, operates or comes from a comprehensive bio-psycho-social approach to the treatment of substance abuse disorders. That is, that you want to bring in the biological and the medical, you want to bring in the psychological, including family systems, and you also want to bring in the social, looking at social variables like socioeconomic status. So her approach to the community reinforcement model is that it's based on the premise that one's home environment or community plays a critical role in reinforcing recovery efforts. Now, this might seem like common sense, but it's often been the case in practice that individuals who are in treatment, the focus is almost entirely upon them, and that there really isn't an effective or continuing aftercare, for example, that would focus on integrating family resources. So there's a real emphasis here on enlisting the support and active involvement of the recovering addict's significant others, including their life partner or spouse. I like very much how Osborne approaches this because she offers some highly practical suggestions. For example, that the significant other, let's say the life partner, would agree not to speak to the addicted individual when he or she has ingested substance. In Osborne's words, to allow natural consequences really to take their inevitable course without enabling behavior that would only support or reinforce the ongoing substance abuse. In the 12-step programs, this is sometimes referred to as allowing the client to hit bottom. Since the home environment is where even addicts in recovery return after inpatient treatment, it makes good sense, doesn't it, to focus on those whose behaviors and reactions, or I might add non-reactions, may actually have the most leverage in helping to create a foundation for long-term sobriety and sustained recovery. Finally, Osborne summarizes what are referred to as the solution-focused approaches to treating substance abuse. I want to touch on just one core assumption that she does a really good job of naming. That is a language of hope. What Osborne suggests here is that use of the word alcoholic, or another word, addict, may actually further aggravate the client's reluctance to be in counseling. I think of it in terms of the shame that can be attached to these terms. Of course, this issue is going to be a source of controversy, especially when contrasted with the 12-step programs that focus on the importance of those very terms. She cites research to indicate, though, that these terms can really be detrimental to treatment for certain clients. So she's suggesting as an alternative a language of hope, which would provide a non-shaming bridge for the addict to move from denial of having a problem to possible later acceptance of having a problem, for example, with alcohol or some other addiction. In other words, that there might be value in considering a more gradual approach to introducing these terms rather than insisting right from the get-go that these be the labels that the addict uses for his or her behavior. The goal, after all, in both AA and solution-focused approaches is very much in common, and that is to empower the individual to begin to take responsibility for his or her life. And the basic question is, what works? And as Osborne summarizes, I think, very effectively, empirical evidence suggests that solution-focused approaches can be highly effective with large numbers of otherwise what are referred to as treatment-resistant addicted individuals. Thank you.